Dear friends, in this presentation we will discuss the role of imaging in carcinoma stomach. As we know that there are several modalities for diagnosis and staging of gastric adenocarcinoma. Those are upper GI endoscopy and endoscopic ultrasound, several imaging techniques and diagnostic laparoscopy. The imaging techniques that are available in gastric adenocarcinoma are barium meal series, multi-detector CT scan, MRI scan and PET scan. Barium upper GI series, so-called barium meal series, is largely replaced by endoscopy nowadays because it has a low sensitivity for diagnosis of early gastric cancer. Even in an advanced gastric cancer, it has a sensitivity of 60 to 70% and a specificity of 90%. However, it is used only for diagnosis. Its role in staging the malignant lesion is very minimal. It can be used to diagnose complications like a gastric outlet obstruction that you can see on the image on the left side of the slide. However, there is a special situation when it comes to employment of barium upper GI series, that is for the diagnosis of Linitis plastica. Linitis plastica is nothing but intramural spread of gastric malignancy resulting in a leather bottle stomach or a leather flask stomach. This results in a decreased distensibility of the stomach, which can be diagnosed by a barium meal series. In an endoscopy, again there will be little or no mucosal abnormality, and only abnormality that we can appreciate is decreased distensibility on insufflation during endoscopy. Similarly, barium meal series can also bring out the finding of decreased distensibility. Coming to multi-detector CT scan, it is the most important imaging modality for gastric adenocarcinoma. If we have to choose single investigative modality for gastric cancer, it will be a multi-detector CT scan because it provides information on T, N and M, namely the tumor, node and metastatic staging for the gastric cancer. Further, it provides data on complications like gastric outlet obstruction and bleeding that will help in prompt surgical management. This particular slide gives us the American Joint Committee on Cancer AJCC TNM staging for gastric carcinoma as seen on a CT scan. Description of CT appearance of T1, T2, T3 and T4 tumors and nodal and metastatic disease is provided in this table. In the subsequent slide, we will elaborate more on this. To begin with, we should understand the pathways of spread of gastric adenocarcinoma. There are 5 different pathways of spread. The first is, of course, the lymphatic dissemination, where the malignant cells can spread to the adjacent perigastric and extraperigastric lymph nodes. The second is what is called the subperitoneal dissemination. It is a unique form of spread where the tumor spreads along the perigastric ligaments to the mesentery and omentum and even to the adjacent organs. This is along the perigastric ligaments. Transperitoneal seeding can occur where there can be drop metastasis of tumor cells to ovary resulting in Krukenberg's tumor and pelvic deposits. There can be direct invasion of adjacent organs from the primary, and finally the tumor can spread hematogenously to distant organs like lung, liver and bone. CT imaging protocol in stomach cancer will be a triple phase CT scan with contrast injection done using a power injector. It goes through in triple phases. The first phase is arterial phase wherein image acquisition is done 25 to 40 seconds after IV contrast injection. During this phase, the tumor is detected. In the second phase, what is called the venous or parenchymal phase, which happens 60 to 80 seconds after the IV contrast injection. This phase is particularly useful in identifying lymph nodes and distant mets. The third phase, what is called the delayed or equilibrium phase, happens 3 to 4 minutes after the IV contrast injection. Here we will be able to analyze the depth of mural invasion on the images. Basically, we can accurately find the T staging. So the gastric wall appearance on an MDCT presents with three layers. The inner layer, which is the mucosa, it is about 1 to 3 millimeter in thickness and it is a high attenuating layer. The intermediate layer is the submucosa. It is of variable thickness and a low attenuation. The outer layer represents muscle propria, subserosa and serosa, and it is a high attenuating layer. So basically the gastric wall will have a three layered appearance with a middle layer of low attenuation surrounded by outer and inner layer of high attenuation. Further, we have to note that MDCT is highly accurate in identifying serosal involvement and adjacent organ involvement by the loss of fat plane. This is particularly useful for a surgeon before planning a gastrectomy. The normal gastric wall thickness is up to 5 mm in a distended stomach, while it is up to 10 mm in an undistended stomach. Compared to the proximal regions of the stomach like fundus and the proximal body, the antrum and distal stomach is little thicker. It may be more than 5 mm and still it may be normal. However, overall, any gastric wall thickness more than 10 mm is supposed to be malignant with a positive predictive value of more than 95%. So, the CT findings in a patient with gastric adenocarcinoma, the number one finding is wall thickening. So, any gastric wall thickening which is more than 1 centimeter or asymmetric focal wall nodularity, then the suspicion of gastric adenocarcinoma is very high. Coming to enhancement, so what happens during the contrast injection? In a patient with early gastric cancer, the enhancement occurs during the arterial or venous phase due to the vascularity of the tumor. In patients with advanced gastric cancer, the enhancement happens during the delayed phase or the equilibrium phase. This is due to the fibrous component of the tumor resulting in a delayed enhancement. So early gastric cancer enhances early, advanced gastric cancer have a delayed phase contrast enhancement. There are certain peculiarities that we need to understand when it comes to T staging in CS stomach. One is spread along the subserosal connective tissue into the perigastric ligaments and into the greater and lesser omentum without perforation of the visceral peritoneum is still T3. For example, if a tumor extends from the stomach along the perigastric ligaments and still the peritoneum over the ligaments is intact without any perforation by the tumor, it is still considered T3 even though the extent of the tumor is away from the anatomical confines of the stomach. Second peculiarity is intramural extension along the digestive tract. Tumor from the stomach can involve the esophagus when it is proximal, can involve the duodenum when it is a distal gastric cancer. So, if intramural extension occurs along the digestive tract into the esophagus or duodenum, it is not considered an adjacent organ involvement or a T4B lesion. For example, if you have a proximal gastric cancer which is T3 and it involves along the digestive tract into the esophagus up to say up to 4 or 5 centimeter, it is still a T3 disease because the primary tumor is in the fundus of the stomach and that is T3. Just because it has involved the esophagus, it doesn't qualify as an adjacent organ or a T4B disease. Further, we need to know that proximal gastric cancer can have distal esophageal involvement in up to 60% of patients and distal gastric cancer can have duodenal involvement in up to 15% of patients. Coming on to the next peculiarity with a T4B cancer in which the tumor spread along the perigastric ligaments and involvement of adjacent organ is still considered a T4B and not a metastatic lesion. For example, if we have a body of stomach lesion and it grows along the gastrocolic ligament and involves the colon, even though it is an adjacent organ that is involved, it is still considered a T4B lesion and not a metastatic lesion. So, in this regard, we should note the five principal perigastric ligaments which can be identified on a CT scan and can be reported by the radiologist as well. These are the gastrohepatic and the hepaticoduodenal ligament, the gastrocolic ligament, the gastrosplenic ligament, and the splenorenal ligament. Coming to a nodal staging on a CT scan, so the lymph node is size is the most important parameter that is used to diagnose it as a metastatic lymph node in the gastrohepatic region or the upper gastrointestinal tract. If the node is more than 8 millimeter in size, it is considered to be abnormal and it is considered to harbor metastatic cells. Other features of lymph nodes that can throw suspicion on it being a metastatic node are a round node if there is a cluster of more than 3 lymph nodes, and the degree of enhancement where there can be hypoattenuation and there can be a heterogeneous attenuation. So these are the features which will tell us that we are visualizing a metastatic node. Overall, the CT scan has up to 89% accuracy in nodal staging. And the other thing that we need to understand is small nodes which are less than 5 millimeter in size cannot be detected by a CT scan, but these nodes can still harbor metastatic cells. Nodal staging is incomplete without identifying the nodal stations. The Japanese have done extensive work in mapping the nodal stations. According to the Japanese Gastric Cancer Association, regional lymph nodes in carcinoma stomach is divided into perigastric and extrapeриgastric lymph nodes. The perigastric lymph nodes are right and left paracardiac, greater and lesser curvature, supra and infrapyloric nodes which belong to station 1 to 6. The extraperigastric lymph nodes are the nodes that are located along the left gastric artery, common hepatic artery, celiac axis, hepatoduodenal ligament, splenic hilar and splenic artery lymph nodes which belong to station 7 to 12. So, enlarged nodes in these locations can also be visualized and reported by the radiologist. So, where will these metastatic nodes be located? If we find a single perigastric lymph node, regional node, 90% of the time it is located on the same side of the tumor. For example, if we have a lesser curve primary, then majority of the time the node will be located along the lesser curve. However, if we have multiple perigastric nodes, then the locations are less predictable. What are skip lymph node metastasis? This extraperigastric lymph node without a perigastric node. This can occur in up to 5 to 14% of patients, and it is more common in proximal gastric cancer. For example, if you have a tumor in the fundus of the stomach, they can have a metastasis in a hepatoduodenal ligament lymph node without any perigastric lymph node. So these are skip lymph node metastasis. We need to be aware of that so as it can help us in planning the lymph node dissection. Regional lymph nodes of the stomach are perigastric and extraperigastric nodes from station 1 to 12. If we have nodes that are non-regional, that are quite far away from the stomach, then these nodes are metastatic nodes or M1 nodes, according to the AJCC Cancer Staging Manual 8th edition. And these are retropancreatic nodes, para-aortic nodes, root of mesentery nodes, and middle colic lymph nodes. Nodes along the superior mesenteric vein are still considered metastatic according to the 8th edition of AJCC. However, Japanese Gastric Cancer Association differs in this particular point, where they consider node along the SMV as a regional node rather than a metastatic M1 node. Another place where the Japanese Gastric Cancer Association differs is infradiaphragmatic, paraesophageal, and lower thoracic nodes in a patient with a when a primary tumor involves the esophagus. In this particular situation, the Japanese group consider these nodes as regional rather than metastatic. For example, in a patient with a proximal gastric cancer with a distal esophageal involvement and a periesophageal lymph node, these are still considered regional rather than metastatic. M1 node according to the JGCA. Other distant nodes are supraclavicular, the Virchow node, and the left axillary iris node, and periumbilical node, which is the Sister Mary Joseph node. Another change that has happened from the seventh edition of AJCC to the eighth edition is the hepatoduodenal ligament lymph nodes. It has now considered to be a regional node compared to a M1 node as in the older edition. So, hepatoduodenal ligament lymph nodes are now considered regional lymph nodes, and we need to understand that. Coming to M staging on a CT scan, in this we need to discern how to diagnose peritoneal disease on a CT scan, so which is a M staged CS carcinoma stomach. So peritoneal disease can manifest as ascites, which is the most common. There are other manifestations like soft tissue nodules or plaques on the peritoneum and bowel wall. There can be prominent fat stranding, there can be irregular peritoneal thickening and enhancement. The so-called omental caking, which occurs due to direct involvement of the peritoneum of the gastrocolic ligament, greater omentum and transverse mesocolon, is another sign of peritoneal disease. Other distant organs that can be involved by the metastasis are lung, liver, and bone, which can also be identified on a CT scan. So, all this will help us in diagnosing the M staging of the gastric adenocarcinoma. Coming to the role of PET scan in patients with carcinoma stomach. In general, in any given patient with carcinoma stomach, the role of PET scan is minimal because the mucinous, signet ring cell, and poorly differentiated varieties of carcinoma stomach have a very low fluorodeoxyglucose uptake, and hence they are generally PET negative. Further, false positive PET is also common when there is inflammation in the form of gastritis and infection. However, studies have shown that performing a PET CT scan in a patient with carcinoma stomach increases the metastatic detection rate in up to 10% of patients, resulting in subsequent change in clinical management. A word about MRI scan in patients with carcinoma stomach. It has been shown that MRI has an accuracy which is similar to a multi-detector CT scan in patients with carcinoma stomach. However, it is generally not widely used because of high cost. Long time is required for acquiring the images in several different phases like T1, T2 phases of MRI, and MRI has a very low spatial resolution compared to a CT scan, and motion artifacts decrease the quality of imaging in the upper abdomen. Motion artifacts occurring due to peristalsis, cardiac pulsation, and respiratory movements are unavoidable during an upper abdominal imaging. For all these reasons, MRI is not widely used even though it has an accuracy similar to a CT scan. So this is a concluding slide where you can see the CT appearance of the various T stages, N stages, and M stages of adenocarcinoma of the stomach. I request you all to go through this for further information. Thank you, dear friends. Kindly subscribe to our YouTube channel for more videos.